بسم الله الرحمن الرحيم.
All right, welcome everybody. We're excited to host our very first webinar from the MCC Health and Awareness Committee. We will be discussing living organ donation in the Muslim community. This is a topic that's been coming up increasingly more uh, frequently over the course of the last few years, as more and more members of our community are increasingly faced with questions about is it halal or is it not, and what exactly does it entail. So our intent is to try to cover some of that today. Our MCC Health and Awareness Committee is dedicated to serving the community both at the Alston location and also at the MEC location here in Morton Grove. This is a community that was newly formed in September of 2020, and our aim is to serve the full needs of our community with regards to age, gender, ethnicity. At this point, the committee is made up of Omar Khan, who is a physician, who's been graduated from medical school and conducted research and working in the community for the last number of years, and myself as a pharmacist, completing pharmacy school training and practicing as an ICU pharmacist before moving into administrative roles over the course of the last few years here in the Chicagoland community. We thought that one of the things that's an impetus for our committee that we want to share with the community, and this will be a recurring theme over the course of the next however many sessions we take this through, but one of the things we want to empower our community members to feel comfortable with is that they should take charge of their own health and be proactive members or participants in their health and outcomes. There are a number of different hadith and Quranic ayahs that encourage believers to be active participants in their own health. We've selected just a few of the hadith from our Prophet listed here, but you should be proactive in taking care of yourself in addition to making dua and asking Allah for help. It's important to remember that your health is a trust. So taking care of ourselves, taking care of our bodies is an important aspect of faith and something that is sometimes misunderstood. But hopefully we can encourage that amongst our community members. We've had a number of previous topics posted. Our first one was colon cancer screening. We had an entire series devoted to mental health during Mental Health Awareness Week. Recently had a series, a very informative video session with breast cancer screening and awareness that we're planning to expand into a fuller webinar soon, inshallah. We encourage everyone to find these videos. They're posted on our Instagram account. Also, we have a dedicated YouTube channel, and you'll also find us posting these videos off of the MCC Facebook account as well.
This may be a perfect time for anyone who is attending this webinar to make note of this. Again, as Ishaq had mentioned, this is kind of a fairly new or revitalized committee that you can say, and Ishaq and I have kind of been the only ones at the moment who have been working to get this back off the ground and to get some programming going. But in order for this to truly be successful, we are looking to kind of build out a team and looking for individuals in all sorts of backgrounds within healthcare that can provide their own expertise and insight. And of course, we can do quite a bit more when we have more hands on deck. So one of the things that we're doing is we're kind of doing a volunteer application process. And so we really want individuals who are committed, who are serious, whether you're already in the healthcare field or are looking to approach a field within that. We're asking for individuals who are able to commit at least 5 to 10 hours a week, whether it be, again, kind of doing some background research on particular topics, putting some information together, reaching out to speakers, things along those lines, even helping with some programming. There's a number of projects we kind of have in the pipeline, and we really are looking for individuals that can bring a great dynamic to the team. So in order to do that, we're asking people to send us an email at health@mccchicago.org. Again, that is health@mccchicago.org. We're looking for people with all types of backgrounds: dietitian, nutritionists, medical students, physicians, pharmacists, respiratory therapists, all types of backgrounds. And again, individuals who can really make a contribution to our communities to kind of take on that next level of health education, building out resources, really being that center of the community and a resource for our community. So if, again, you or anyone you know is interested in volunteering and committing a bit of time to expand this, opportunity or this committee that we have, we ask again that you do please send a personal statement about your interest, as well as a CV and resume to health@mccchicago.org.
I will say, if you're skilled with social media, that's really appreciated.
Yeah.
Right now, Omar's putting in the lion's share of the work with our Instagram account.
Yeah, absolutely. So that'll help as well. So we do also want to share a quick thank you for anyone that's listening in on this webinar. Everyone that's kind of involved in this is they're all volunteers. Whether it is the individuals on the panel who are speaking, this time frame that they have that they're speaking is not the only time that they've put into this. They've actually done PowerPoint presentations prior to this. We've had a couple prior meetings as well, constant communication with us. So we really do appreciate the panelists really taking out time out of their busy schedules to share their wealth of knowledge and their experience, and again, to be a resource to our community, to provide some education and to start some of these important conversations that maybe don't happen as often or as frequent. The other thing that I do want to acknowledge is that even though you see Ishaq and I right now as the face of this Health and Awareness Committee, this type of webinar or these types of programs are not really possible without the support of the community at large, in a sense, right? So we've got Akhtar Uncle, Sister Anjum, other members of the MCC committees who have provided resources, who have provided guidance, who are mentoring in some capacity to really help us get this stuff off the ground, or get these topics off the ground. And you see the American Sign Language interpreter, this is Sister Balbina. We really want to say thank you to her as well. She is also volunteering her time to interpret this conversation for anyone who wants to gain this knowledge, but again, may need sign language in order to do that. So there's a lot of people, again, behind the scenes that have really helped get this off the ground. I also want to say a special thank you to Sana Khan, who happens to be my sister-in-law. Thank you for putting together the flyer and for putting up with the countless messages that I would send as far as, constant revisions that we've been asking for. So thank you for that as well. So again, that just says that there's a number of people involved in making this happen. So, we've got a list again of speakers for today's conversation. And so if we can get started, the first person I'd like to introduce is Imam Ibrahim. He is the MCC and MEC Imam, and he brings a great deal of knowledge in both secular and religious education. So part of his conversation, again, will be some of the religious aspects, but there are other personal, stories that we are going to be sharing throughout this conversation as well. And so, again, as I had mentioned, it's going to be beyond faith-based, and we are very fortunate to have him speaking with us today. And he is also an individual that was really pushing for this topic to get out there. And right before we start, again, for anyone who is attending this or who is watching this, we're asking everyone, if you look at the bottom of your page, you'll see a Q&A. You can send in your questions there, and at the end of this webinar, we'll try to get some of those questions answered. If we don't have enough time to get those answered, you can share your email address with your question, and we'll try to follow up with you soon after. So I'm going to get Imam Ibrahim on right now.
Assalamu alaikum wa rahmatullah. Bismillah ar-Rahman ar-Rahim, wa salatu wa salamu ala rasulil amin wa ala alihi wa sahbihi ajma'in. I thank the Health and Awareness Committee for this initiative, and it's, as you mentioned earlier, it's a very important topic that should be talked about, and it's a long overdue conversation. We ask Allah subhanahu wa ta'ala to protect our congregants and our family members and our loved ones, and to give us all the best health and mental health and physical health in this life, and to allow us to be appreciative of it so that we are rewarded for that appreciation in the next life. And so, when we talk about organ donation and these topics in general, anything that has to do with the realm of medicine and health, it's important to mention one of the traditions of the Prophet ﷺ, where he says that take advantage of 5 before 5. And one of these 5 is to take advantage of your health before your sickness. And if you look at the language, it's almost inevitable that you will be afflicted with some sort of sickness or some sort of difficulty that you would have to overcome. And so when you realize that it's inevitable that you will fall sick, or you will fall ill, or there will be a challenge somewhere down the road, then you grow more appreciative of what you have. And it's important to take care of your bodies and to take care of your health. Actually, there's one story of one of the scholars of the past. He lived until he was over 100, and he would go in the masjid and he would move stuff around and clean the masjid and so on and so forth. And his students would ask, how are you over 100 and you're still doing this? And how are your limbs still serving you? And he said, I took care of them when I was younger, and now they're taking care of me when I'm older. And so investing in your health is extremely important. It's extremely necessary because, on one end, you don't want to be burdened with, these difficulties, so that you don't want that difficulty to become an obstacle with your relationship with Allah subhanahu wa ta'ala. Even though sometimes people would go through these difficulties and that enhances their relationship, you don't want to run the risk of being busy going to the doctor and so on and so forth, where you could be spending that time in salah if you would have taken care of your body. And so taking care of your body is extremely important. But if something does happen, then that should double your relationship with Allah subhanahu wa ta'ala, because the believer is blessed in all of his situations. If it's good and he is thankful, he is rewarded for it. And if it's bad, if it's something difficult that befalls him and he is patient, then he is rewarded for it. Ultimately, the outcome that we're looking for is not necessarily the pleasures of this life, it's the accountability that we face on the Day of Judgment, that we stand before Allah subhanahu wa ta'ala and we say, that we took care of what Allah subhanahu wa ta'ala gave us, and we are rewarded with that, with Jannat al-Na'im. May Allah subhanahu wa ta'ala make us from the people of Jannah. Another gift that's extremely important to mention, and it's very relevant to what we're talking about, is the gift of family. And this is personal for me as well. My father, he had kidney failure, and I actually went through the process of donating the kidney to him. And so having your family around and taking care of your family, this is the most important investment that you could do. The Prophet ﷺ, he says, even something as simple as feeding your spouse, that has a reward in it. And you want to seek the pleasure of God by taking care of your family and making sure that everyone is safe. And wherever you guys, whatever difficulty befalls you, you stand together as a unit, because that is what a Muslim family does. These are the characteristics and traits that the Quran tells us. وَالَّذِينَ يَصِلُونَ مَا أَمَرَ اللَّهُ بِهِ أَن يُوصَلَ. Those who link what Allah commands them to link, meaning the families, to connect with the families and to take care of that relationship. So we ask Allah subhanahu wa ta'ala to strengthen our family ties. I don't want to take too much time because we have more important speakers and we want them to give their input before the time runs out. So I'll try to be as brief as possible. The question that many people ask, we're talking about living donation. We're not talking about post-death, we're talking about living donation. People ask, is this something that I can do? Is this a procedure that I can go through with Islamically? When we look at haram and halal and try to understand where does the religion stand on this, you'll find that very briefly, a lot of the Muslim conventions, the fiqh conventions, they have almost unanimously agreed post 2015. I'm talking about the international conventions that you see all the time. it seems as if it's a unanimous agreement that a living person can donate something from his body as long as certain conditions are met. And these conditions are very simple. The first is that you can live and live comfortably afterwards without that organ. And so if it's a blood donation, if you're donating your blood, or if it's a kidney, you can live comfortably afterwards. That's one of the conditions. The other condition is that the donation itself does not maim you outwardly. That, for example, you can't donate your nose or your eye or an ear or something like that, because these things maim you. And so you want to make sure that this donation does not outwardly maim the individual. And then the last condition, and this is actually one of the most important, is that it is what we would say a last resort, meaning that you've exhausted all other efforts, and it's not a casual decision. This is your last decision that you have, and you're cornered. So for example, somebody who is facing kidney failure, complete failure, where they are completely reliant on dialysis. Dialysis is not really a comfortable way of living. It's something that's extremely difficult. It's strenuous, and anyone who goes through it really will say how difficult it is of a lifestyle. And so medication probably wouldn't help at that point. And so the best option would be a donation, or for example, taking from the list, or being on the list of post-death. And so the last condition is that this is a last resort, that you have no other option, and you go through with it from there. A lot of these direct fatwas are conditional, so we leave these broad-ranging conditions, or circumstantial. We leave these broad-ranging conditions so that people understand generally where we're coming from. Now, as a donor, people would ask, what's it like being a donor? What is it? How is that lifestyle? What is it? What do you have to go through? And being a donor starts not with the actual donation. It starts with the experience of the family member or the person that you're living with that really goes through that organ failure. And so for me, it was the struggle my dad went with, where some of the struggles are he would, instead of urinating properly, he would vomit. And we would hear it, and it's something that it's painful for the people in the house, not because it's a nuisance, but because someone you love is struggling, and you hear the pain in their struggle. Some of the things my dad would describe is that he felt that there was a fog around him, and he wouldn't be able to focus, and he wouldn't be able to properly do a task, and it was extremely difficult. And then when he went into dialysis, it drains you completely as an individual. And so we're seeing this as family members, and it's something that tears your heart. And so my mom, she came and she told me, she's like, look, your dad most likely is not going to want to accept an organ from you, but let's just go to the hospital, me and you, and let's see which of us is a match, so that we can go through with the surgery. At least we'll figure out, is it possible, is it not possible, do we have the same blood type, so on and so forth. So me and my mom went, and for those who are going to go and go through this procedure, prepare to get a lot of shots. There's going to be a lot of blood drawing, there's going to be a lot of shots. So they took our blood, and then later on it came out that that I was a perfect match with my dad. They said that this is like kind of the dream match that you would want, a father-child, and it's the exact blood type. And so we went through with the procedures moving onward, and more tests that they went through. Eventually we scheduled a date, and we told my dad, this is what we want to do. And the whole time my dad is reluctant, and he's saying, no, you can't do this, I'm not going to do this. And as the date got closer, he got more insistent that we're not going to go through with this. So I remember there were two things that changed my father's mind. The first thing was that I sat down with my dad, and I told him, look, and this is because he raised me this way. It's not on my own virtue. This goes back to how he raised me, and so it's his credit. I told him, look, Dad, whether you take the kidney or not, I'm donating it, right? I've already made my my mind that this is going to be donated. So you can reject it; it's going to go to someone else, or you can take it. The reason I'm doing this is not for you; it's for the pleasure of God. It's so that on the day of judgment, this can be seen as a reward. And we ask Allah subhanahu wa ta'ala for sincerity. We ask Allah subhanahu wa ta'ala to guide us to its best. And so that kind of, it showed that, we're serious about this, and we're not, it's not just, a flimsy decision. And later, to reassure my dad, my siblings all came and they said, we're here, we're with our brother, we'll take care of him. And so I know that my siblings will take care of me if I ever go through anything. And so family sticks together. This is an extremely important value when it comes to facing these kind of difficulties. You want to have a network of people around you that support you. Going through the procedure itself, I remember the way they described it, and I'm sure the surgeon and the other medical professionals would describe it, but it was painful. I was put to sleep and I woke up with 3 different IVs, 2 in one arm and 1 in the other. And it was a very difficult, it was very painful. But, subhanAllah, years later, I don't really, you can't really pinpoint how painful it was, because your memory just, I guess, plays with your memories in the past. But it was something that was really difficult. I do remember that they were telling us, usually the recipient is the one who walks first, right, after the surgery. And I made it a point that, no, I'm going to be the one that walks first. And so I insisted, and I had the nurse, she was with me, and we were walking towards my dad's room, and I was holding really tight onto her arm to the point where she was like, you need to relax, but I was able to walk first and tell him, to see him and make sure that he was okay. One of the most beautiful things the doctor said was that before they even closed everything up, they simply connected the urinary tract and artery and vein, and the kidney was already working. It was already working. And my dad said that fog that was around him was lifted, and he felt comfortable again. And alhamdulillah, it's been 6 years since then. Alhamdulillah, I've gained a little bit of weight, but that's my fault. Otherwise, alhamdulillah, I feel fine, I feel great, and I have my father. That's the most important thing. And so, it's a decision that, when it comes to your loved ones, I'm sure anyone would make a similar decision. Allah subhanahu wa ta'ala, he says, وَمَنْ أَحْيَاهَا فَكَأَنَّمَا أَحْيَا النَّاسَ جَمِيعًا. Whoever provides life for one individual, it's as if they have provided life for all of humanity. And so, I guess the point that's the most important point here is to do it for the sake of Allah subhanahu wa ta'ala and earn that reward. And with sincerity, you'll find blessings. And inshallah, these surgeries, these procedures that they'll be successful moving forward. And you'll find, having your family around is the biggest blessing. May Allah subhanahu wa ta'ala guide us to its best. I believe I went over my time, and I want to make sure that everyone has the opportunity to speak. Jazakumullahu khairan. Assalamu alaikum wa rahmatullah.
Salam, and thank you, Imam Ibrahim, for sharing, again, not only some religious insight, but also for sharing such a personal story. I know you've really been wanting to champion this conversation to bring a bit more insight and knowledge to our communities, as there are many misconceptions and misunderstandings around this topic in particular. So again, I'd like to thank you for leading this conversation. And next up, I do want to introduce Dr. Mohammed Ahmed. As we had mentioned, this conversation is going to involve a number of healthcare professionals as well as individuals sharing their personal stories. But Dr. Mohammed Ahmed is native to Chicago. He went to Chicago College of Osteopathic Medicine and graduated in the top 5% of his class. So again, thank you to all the experts that are really providing their time to share this knowledge and their expertise. And he went on to complete his nephrology fellowship at Loyola University Medical Center, and then went on to complete his critical care fellowship at Mayo Clinic. Dr. Ahmed currently works as a senior consultant with Nephrology Associates of Northern Illinois, also known as NANI, and is known for his teaching skills, and again has been recommended to us because of the great way you're able to really share your knowledge and get people to really understand what it is that you're trying to teach them. So we are excited to have you, and thank you again for your time. And so I will, again, kind of go out into the background, and you can feel free to kind of take over from here.
Assalamu alaikum, everyone. I was asked to do this to really help our community understand first the value of transplantation, and since we're focusing on the kidneys, they've asked me to give a little background on what the kidneys do in health and what happens when they become diseased, and what are the options that are available for folks who are dealing with kidney failure. So that's kind of the objectives of the talk today. Is we'll go through where the kidneys are, what they do, how can one measure kidney function, what causes the kidney function to go down, and when it starts to go down, what can you do to help reduce the rate of progression of kidney dysfunction? What can you do to keep your kidneys healthy? And when they completely fail, what are the options? Before getting into the bulk of the talk, I wanted to echo some of the things that the Imam said, that when Muslims come to the table of having any problems with their health, what we must realize is that, number one, this is a challenge that God has given us. And with the challenge, He has given us resources to take advantage of. And it's up to us to, inshallah, take advantage of those resources and do what we can so we can live a healthy lifestyle and, inshallah, live many years of more Ramadans and more sajdas and more opportunity to engage with our Lord. So with that being said, let's dive into what the kidneys do, where are they, and what's the overall function of the kidneys. So simply put, the kidneys are two organs that are bean-shaped. They're about the size of my fist in height. And the area that's occupied by the kidney filter is the thickness of my finger. So the kidneys have a lot of different functions in our body, but a majority of the function that's done that we replace when we put patients on dialysis is the kidney's ability to filter out poisons, toxins, and garbage that our body produces. So I have this image here, as you can see, the kidney, I have it in sort of a vertical or horizontal, platform. And the reason why I did that is that we think of the kidneys like the washing machine of the body, that you have 3 tubes that connect the kidney to the rest of the body. 2 of them are blood tubes, and 1 of them is a drainage tube. Just as we put in dirty clothes into the laundry, in this organ, the kidney, dirty blood that has the garbage and toxins and poisons that our body produces will enter into the kidney. Then through a process of filtration that happens throughout that kidney, the garbage will eventually be filtered out, be funneled into a drainage system that'll eventually drain that garbage and that urine into the bladder to be excreted to the outside world. And then once that garbage has been filtered out of that blood, the clean blood then leaves the body through the renal vein, which is what you see depicted in blue vessel there. So when the renal artery, which is that red blood vessel that you see coming in, when that comes in to the kidney, it breaks up into tiny, tiny branches that eventually terminate on a filter that is the filtering unit of the kidney. And as I said, that you have a kidney that's about that tall and filters that are occupying a space that's that thick. You have 1 million filters in each kidney if you're born of normal age and normal gestational age. And so they're very tiny blood vessels. And so what you will realize is that most of the things that cause kidney disease in the United States are things that cause blood vessel disease. And we'll talk about that in one of the subsequent slides. So as we said, the kidney in health normally filter out garbage that our body produces. And so how do we measure when kidney function is not normal and when the kidney function is declining? Well, simply put, one could measure the garbage level in the body. And if the garbage levels are high, then you can assume that the kidney is not doing what it's supposed to do. So garbage, turns out, is very expensive to measure. And what we do is we use a marker that is about the same electrical charge and molecular size as garbage is. And if that level is high in your blood tested by a blood test, then you know that the garbage levels are high, and hence the kidney is not doing what it's supposed to do. Furthermore, as we said, that the kidney is a filter, and the filters have holes in it that allow garbage to pass through. If that kidney filter, the holes are large enough that's causing the things that are not supposed to be filtered, like protein and red blood cells, the things that are supposed to be held inside that filter, if the holes get bigger, then those components of the normal blood will then pass through the filter, enter into the urine, and damage the filter along the way. So how do we measure kidney function? We measure a blood test called creatinine. As the creatinine levels are rising, we can assume that the garbage levels are rising and the kidney's not filtering it out. We can see in the urine that the patients are spilling protein or other components of the plasma that should not be filtered through those tiny holes. And if that's ending up into the urine compartment, the kidney's not doing a good job at maintaining the filter. So when the kidneys don't work, we generally can do it by lab tests that we just discussed. And unfortunately, what makes my job very difficult is that majority of the kidney patients that I see that present with an even advanced kidney disease, they don't have any symptoms that would point towards the kidneys. You know, when someone has problems with their heart, they can see, they may have started having some chest pain, they go to their doctor, and they're convinced that I've got something going on with my heart. Or if they have a problem with breathing, then they know something may be wrong with their lungs. On the other hand, if they wake up, their eyes look yellow, or they have some jaundice, then they know something's wrong with the liver. I have patients who have kidney function of 10%, 15%, and they feel like they're doing okay. But then I come and tell them that you are near dialysis, and they have a hard time believing that, because this is not a disease process that causes overt symptoms that one can point towards the kidneys. But if we were to look at some of the symptoms that patients would present with, they may have some swelling in the legs, they may have some problems with foaminess in their urine, they may start seeing blood in their urine, but all told, the symptoms are not symptoms that you can point towards the kidney themselves, and they're somewhat ambiguous. Now, what is it that causes patients' kidneys to fail? Broadly speaking, as we said, the filters are themselves blood vessels, the terminal endpoints of blood vessels. So anything that causes disease of blood vessels are eventually diseases that may cause problems with the kidneys. So if you look at in the US, a majority of folks that have issues with blood vessels, those issues are caused by progressive diabetes and progressive hypertension that's not under good control. The other, smaller proportion of patients may present with a dysfunction of their immune system, where they are exposed to some trigger, be it environmental, infectious, malignancy, even emotional stress, whatever that trigger may be, that elicits a response in the immune system, and now the immune system causes collateral damage in the kidney. And then a smaller proportion of patients may have a genetic mutation that's either acquired or inherited that can eventually lead to kidney disease as well. But the thing to point here is that this is really a combination of nature and nurture, that one patient may have a certain genetic makeup, another patient has another genetic makeup. They may have diabetes to the same extent, both patients, but one patient's genetic makeup causes the kidney disease to progress at a much more rapid fashion versus another patient. But the underlying take-home point is, indeed, it is nature and nurture, both that cause the progression of kidney disease. But until the kidneys fail, or until you have your first heart attack, or until you have that stroke, it is up to us to understand the disease process, take ownership of it, and do what we can to optimize the risk factors that are causing the disease to progress. So it is a combination of nature and nurture. So when you have chronic kidney disease, or the acronym here is CKD, we touched on this. How do you know if you have it? Well, you can do a blood test, and the blood test can show that your creatinine level, which should be less than 1, is increased to more than 1.0. Or you may have some symptoms of foamy urine, like we talked about, or increased swelling in the legs. Majority of the time, it is silent disease. And so once you know that you have kidney disease, what can you do to prevent the progression? First, the job of our caring nephrologists is to do the best that they can to diagnose what the cause of it is. Is it diabetes? Is it high blood pressure? Is it a genetic problem? Is it something else? And then what can we do to optimize the thing that caused the kidney disease? I've had patients who've had diabetes for 25 years. They present to me with kidney dysfunction, they present to me with eye dysfunction, and we do everything we can to optimize that diabetes. And in fact, their eye disease reverses to some extent, their kidney disease reverses. There are those patients that will present with very advanced disease, And in those patients, we'll see that we can at least slow the rate of progression and delay the need for dialysis. And alternatively, if you have a genetic problem that's causing it, then there may be some disease-modifying strategy that the kidney doctor can invoke. So when the kidney function does go down to the point where the kidney function needs to be replaced, what is that point? It's not one number. Some people will say that when your creatinine is in the 4.55 range, or if the kidney function percentage that's calculated by the creatinine value, when that level goes down less than 15%, less than 10%, the kidney function needs to be replaced. Really, it's not one number. It's the overall picture as to the number plus the actual patient and how they're feeling. Once the kidney function gets to the point where it needs to be replaced, you really have three options. Two broad options, and then there's a kidney transplant. So let's first talk about dialysis. So dialysis is basically the ability of using this resource that allows us to replace kidney function and give some of that function back, and help filter out some of the poisons and garbage that your body's producing, which your kidney can't get rid of. There are really two main ways of doing dialysis. There are a few other modalities as well, but the two main ones that we'll discuss briefly are hemodialysis and peritoneal dialysis. In the context of hemodialysis, you have to have a way that blood leaves your body, enters into a machine that filters out the garbage, and then that cleansed blood will then be delivered back into your body. That access could take the form of an IV access that's there, or it can be a fistula that's created by a surgeon in the arm. Suffice it to say, this form of dialysis is one that if your kidney works 24 hours a day, 7 days a week, you are cramming what the kidney does doing hemodialysis 3 times a week, about 4 hours each time. So there's a lot that's happening in a short period of time. So generally speaking, patients who are overall unhealthy because of heart problems or because of advanced age, they may not tolerate that modality of dialysis very well, because you're doing a whole lot in a short period of time, and you have a lot of fluctuations of fluid balance and electrolyte balance that's happening during that short time. Peritoneal dialysis is a surgeon places a tube into the empty space in your belly, and there's fluid that's clean that goes and hangs out in that belly, in that empty space through that catheter. While that fluid is there, it's clean, and the intestines and the lining of the abdominal wall has blood vessels that have garbage in it. That garbage will leave those blood vessels, enter into that fluid, and that fluid will then get drained. And then over the course of the 10 to 12 hours that patients are on peritoneal dialysis on a nightly or a daily basis, their blood will be cleansed with this fluid entering, washing the blood, and then the fluid being drained. That does not involve blood, and it is actually a lot better tolerated by patients, because again, they're doing a therapy every day, and it's a lot gentler on the body because of the duration of time that you're on peritoneal dialysis. The thing to note is, as the Imam was saying, is that even though he was a compliant patient, even though he was doing what his doctors were asking him to do, he still felt that he was in the midst of a cloud, and he still felt this weakness, and he just was not himself, and his overall ability to perform and function was not the same as it was before he went on dialysis. There are a lot of different reasons for that, but one reason that one could note is, when you do what you're supposed to do, you're only adding 10 to 15% kidney function to your body. So if you're starting off with the kidney function before dialysis, or what your normal kidneys are doing is 5 to 10%, by adding 10 to 15% more kidney function, you're only adding that much removal of garbage. But that is enough of a survival advantage that we're able, that without causing the healthcare system to go bankrupt, we're able to provide that minimum amount that we can get away with to allow for an advantage in terms of survival. The best option is kidney transplant, and you can have a patient that has a kidney transplant. They get a kidney that is donated through them, either from a living donor or a deceased donor. When that kidney goes in, they can have a creatinine, which I said is less than 1 normally, of let's say 12, 13, 14. And within hours to days, that creatinine, if that kidney takes and it's doing well, that creatinine can go down potentially to less than 1, which is normal. So you're providing 50, 60, 70, 80% more kidney function than you did before you had the transplant. So that cloud is no longer there. You're a lot more functional. You're a lot more energetic. You don't have the need to be stuck, with blood, leaving your body 3 times a week, or being stuck to the peritoneal dialysis machine on a daily basis. The quality of life indeed improves, and that is the best way to replace kidney function. So in summary, we must come to the with this understanding that if God has given us the challenge of having kidney disease or whatever kind of disease, our job with the resources that Allah has provided us is to first take ownership of the fact that we have this challenge. Once we take that ownership, then our job is to do what we can to understand why we have it, to work with our healthcare providers, to wrap our hands around all of the risk factors that are causing that kidney dysfunction or cardiac disease or whatever disease it may be. What are all the risk factors that are causing progression of that disease? Take the bull by the horn and do everything we can to slow the rate of decline. And there are strategies for pretty much everything out there until you get to the point where the kidney function is completely gone, or you have end-stage heart disease or end-stage lung disease or end-stage liver disease. There are disease-modifying strategies available. And our job, is to take advantage of all of those resources and do what we can to give ourselves more Ramadans, more opportunities to do sajda, more subhanallahs, and more zikr, because that's the purpose of our creation, inshallah. So with that being said, I'd like to conclude. If there are any questions, I'll be available to answer any questions, but I want to leave enough opportunity for the transplant folks to also give their thoughts as well. Assalamu alaikum.
Assalamu alaikum. Thank you, Dr. Ahmed. That was very informative. We really appreciate your expertise on the topic and on the subject. Next is Dr. Nitin Katariya. I wanted to welcome him and invite him to the panel here. Dr. Katariya currently is an attending transplant surgeon here at the Northwestern University Feinberg School of Medicine, with appointments at Northwestern Medicine and also at the Ann and Robert Lurie Children's Hospital. Dr. Katariya went to medical school here at Northwestern University before traveling to University of Texas Health Sciences Center for residency training, and then further coming back for transplant surgery training. We welcome him and his expertise to the panel. He is a transplant surgeon specializing in liver, kidney, and pancreas. So with that, let me turn it over to you. Thank you.
Good morning, guys. Hopefully everybody can see me. I'm going to just share my presentation here. So I'm one of the transplant surgeons here at Northwestern. I've been doing transplant for over 10 years now. And the purpose of my talk today is just to kind of review some of the basics about transplant. It can sound like an overwhelming experience, and we're just here to help you get through that process. And I appreciate everybody's comments so far, talking about the process, talking about kidney failure, and hopefully this will tie up some of that, okay? So I'm going to talk about, obviously we're focusing on kidney today, but there's also needs for liver and pancreas transplant, but I'll start with just some basic transplant facts, review the indications for each organ type, and then distinguish a little bit between living and deceased donation, review our clinical outcomes, and then lead to our transplant coordinator who can talk about the pathway to transplant, okay? So a little bit about transplant facts. So it's a lot for a lot of patients. It's waiting in line. It's a long list. We do in the U.S. about 23,000 kidney transplants a year. About 6,500 are living donor kidney transplants. We do about 9,000 liver transplants a year. Only about 250 of those are live donor liver transplants. And then we do a number of pancreas, heart, and lung transplant. But as you can clearly see, there's a lot more people on the wait list. So you see this screen to the screen right, the number of people waiting for transplants is very, very high. For kidney, there's almost 100,000 people waiting for a kidney transplant. And so we just don't have enough kidneys. And so living donation is a way to help a lot of those on the wait list. It doesn't require anybody to be on the wait list. Then you have direct access to a kidney or a liver. And it gives people who don't have living donors the opportunity to get access to the deceased donation. So we think living donation is always in our mind first option if we can do it. A couple about transplant facts. So one of the things that you need with transplant is you need lifelong immunosuppression medications. These are medications that lower your immune system function because your body still sees the organ as someone else's, and it's doing its job. It's trying to protect you, like it treats it like a bacteria or an infection. And for us to not reject the organ, or for our body not to reject the organ, we need to take these medications to lower that response so your body sort of accepts it. But there's good and bad with those medications, and so we have to balance all of those things. For kidney and pancreas transplant, you need two things to find a match. You need a blood type compatibility, and you need what's called a negative cross match. This is where we test your immune system's response to the donor, the person giving the organ. And if you have a huge immune response, sometimes that cross match is positive, and that's not a good organ to give to you. For liver, it's really just blood type compatibility, okay? Now, what's the difference between deceased donation and living donation? So deceased donation is done by donors who are legally brain dead. They've had a catastrophic injury, brain injury, and they've lost their life, okay? And people on the wait list basically get access to these organs, okay? And the wait lists are monitored and managed in different ways. For kidney, the main thing to get you high on the wait list is your time on dialysis, okay? So if you've already been on dialysis or had kidney dysfunction for 5 to 7 years, you have sort of 5 to 7 years of wait time. So that puts you ahead of someone who's only been on dialysis for 1 year because your need is higher. We're trying to share this limited resource and give the sickest patients the easiest access. In the same sense, for liver, it depends on just who's the sickest. And we have a score that we calculate called the MELD sodium score. And the sickest people get put on the highest on the list because they don't have a lot of time. And so they need access to the livers available quickly, okay? And then pancreas is also based on wait time, like the kidney, okay? In terms of living donation, it's a whole different ballgame. But it can be a family member, a friend, or an acquaintance who can donate, or somebody even, we have sometimes people come to our transplant center who say, I want to help the world. I don't have anybody who needs a kidney, but I want to donate a kidney. And this happens very frequently. And we're open to that, okay? We just have to make sure there's no sort of negative aspects to this. So we make sure there's no coercion. Nobody's forcing someone to do this. Nobody's getting paid to do this. This is out of the goodness of their heart. When people do living donation, we typically take the left kidney or the right lobe of the liver. Interesting thing about livers is if they're healthy, they grow back. So if someone donates part of their liver, it grows back in both the donor and the recipient. And part of our workup of people who want to be potential donors is we make sure that they have no risk factors for kidney or liver failure themselves. So if you have diabetes, you cannot be a living kidney donor because you already have some risk for kidney disease yourself. So we are only taking from healthy individuals who we're not adding increased risk of them having organ dysfunction in the future, okay? And we have programs within our system that can be a donor champion for. They can help find donors. So we really are trying to make this an efficient process to get you off dialysis because as you guys clearly heard, that's not a great way to live. It only gives you 10 to 20% extra function, but people still do not feel well. They do not have great energy. And a functioning kidney is so much better. And in terms of workup, if someone in your family or someone who needs an organ, we can do that within even a few months or a few weeks, depending on how sick they are, okay? So let's talk a little bit about kidney transplant. So this drawing on the screen right is showing where the transplanted kidney is put. So when we do a kidney transplant, we typically leave your old native kidneys in. For most patients who need a kidney transplant, their old kidneys have scarred down and are not in the way. So we make a little pocket in the pelvis to put your new kidney, and we hook it up just like it was described before, an artery and a vein, and then a ureter, which is the tube that drains the urine to your bladder. So for most people getting kidney transplant, they will urinate the same way to do that. And on the right is just a picture of sometimes we'll put kidneys on pump for deceased donation if it's out of the body a long time. Now, treatment options, which was mentioned before for kidney failure. So ESRD or end-stage renal disease, which is where you have kidney failure, you have 4 options. If you do nothing, eventually you'll die from your kidney disease. We have dialysis. We have the hemodialysis and peritoneal dialysis. And then we have two different ways to do kidney transplant. We have deceased donor kidney transplant and living donor kidney transplant, okay? And today we're really focusing on living donor kidney transplant. So the two options are, if you have a compatible donor, great, we do the living donor transplant. But some people have a good donor, but they're not compatible with them. So we have programs where we can do what's called a kidney paired donor exchange, where we will share two organs amongst the other group. So take, for example, you see here in the left corner, or screen left, we have two donors and two recipients, and they basically swap kidneys. That way we're helping both families with these incompatible organs. And sometimes when you have an incompatible donor, we can also do what's called desensitization, where we sort of calm your immune system so that you'll accept it, even though it's not quite compatible. This is probably the most important slide I'm going to show today, okay? And this is talking about life expectancy on dialysis versus getting a kidney transplant. On the left will be your age, okay, with the top being the youngest age, 20 to 24, all the way to 75 to 79. And then on the bottom shows your expected remaining years of life. And so you see in the gold, the yellowish gold color, this is what people's life expectancy is on dialysis at the different age groups. And as you see, as people get older, your life expectancy is shorter if you're still on dialysis. But you can still get some meaningful life with dialysis. The blue shows how much additional life you get if you get a kidney transplant. So take, for example, a 20 to 24-year-old with kidney failure. Their life expectancy on average is 17 years. But with a kidney transplant, it's almost up to 45 years. So it really makes sense for them to get transplanted. Okay. Otherwise, they're going to have a more challenging quality of life, and their health in the long term will deteriorate. And we see this benefit even into your 70s. Okay. If you look at the bottom of the graph of the 70 to 79-year-olds, their life expectancy is only a couple years on dialysis, but you can double or triple that with the transplant. Okay. So for most patients, it really makes sense to consider kidney transplantation. Okay. So a little bit about being a living kidney donor. So we talked about it earlier, but I'm going to review again. They're expected to return to a normal life and health after donation. I've had two family members donate kidneys, and you wouldn't even know it. It has not affected their health negatively in any way, okay? Donors don't have to be related to you. We do the surgery minimally invasively, meaning we make very small incisions and we use a camera to do the surgery, okay? So if you look on the left there, we make two small incisions and one bigger incision we have to make to take the kidney out. And as was mentioned before, the kidney is about the size of your fist. So we have to make one incision about this big. But people do very well. You really only stay in the hospital overnight, go home the next day, and your recovery time's a few weeks. People do very well, okay? So in that sense, from a surgical standpoint, we really advanced. 20, 30 years ago, we used to make a big incision, or we'd make an incision in the back. People were in the hospital several days. But we've advanced the technology to make this a very sort of efficient, safe process and minimize pain. Of course, you're going to have some incisional pain after surgery. We give you pain meds, and people recover quickly, though, okay? And there's also some concerns. People have concerns about if I'm going to be out of work for a few weeks, and all types of financial and social kind of concerns. We have excellent social workers who work with us to help you through this process. If you're going to be a donor, the recipient, the person who's getting the transplant, their insurance pays for all your surgeries, your medical bills and stuff. There's even programs to help with lost wages if you're missing work for a few weeks. So in the US, we're really trying to encourage living donation, and there's a lot of ways to make it happen, okay? Another great thing built in the system is if, for whatever reason, a donor developed kidney failure in the future and they're a kidney transplant candidate, okay, someone who donated a kidney and now they need a kidney transplant, you get put near the top of the deceased donor waiting list. So we have this safety mechanism that as a donor, a kidney donor, you don't have to have that fear, okay? But it's our job to make sure you don't have risk factors for kidney failure. So we do blood draws and some shots, like was mentioned, to make sure that it's safe for you, okay? And then does a kidney donor need medications or change that or restrict activity? In the long term, no. You'll get some pain meds and some stool softeners after surgery. You don't have to change your diet much, and your activity is only restricted in the peri-surgical time frame. So meaning for those first 4 to 6 weeks, no intense physical activity. After that, you can get back to everything you used to do. In terms of our kidney transplant outcomes, we have excellent outcomes here with survival in the 90+ percentile, even 95+ percentile. So people do very well following transplant, okay? I'm going to touch a little bit about liver transplant, okay? So your liver does a lot of the things that were mentioned before. It also does a lot of filtering of garbage or toxins, okay? It makes a lot of the proteins for your body. It helps fight infections. It makes bile, which is important for nutrition, absorption of a lot of vitamins, and it metabolizes other things. So it has a lot of functions, okay? These are a bunch of the different potential causes of liver failure. The most common things that we see in the US are alcohol, fatty liver disease, and we used to see a lot of hepatitis C, but we have very good medications for that, so that's going away. And then there's some genetic diseases as well that can happen. Like primary sclerosing cholangitis. So there's a lot of different causes, okay? But becoming a liver donor is another option. These patients, we have dialysis for kidney failure, but we don't have dialysis for liver failure. So for patients who have really what we call end-stage liver disease, or their liver is not doing well and they have cirrhosis, there's no dialysis. So they need a transplant or they'll die. And so we have both options in the U.S., deceased donation, living donation, but being a living liver donor is similar to being a kidney donor, okay? You need to be motivated and there's no coercion. There's, you have to be pretty healthy in general. Your body mass index or your weight has to be reasonable, okay? And generally, to be a liver donor, you have to be a little bit younger than potentially a kidney donor. We say ages 18 to 50, okay? Typically, living liver donors we have to be a little bit more strict, because also when we're doing the surgery for the donor, we're splitting their liver and their anatomy has to be very conducive to protecting them, but also be able to put back together for the recipient. And so donors, most patients need a couple donors to come forward because one of these things rules them out, okay? But it's a very similar process to the kidney donation. So when you're a living liver donor, we make one small incision at the bottom there, and we do part of the surgery laparoscopic. So again, patients are only here a couple days. They do very well. Here's a scar from one of our donors, healed up great. In terms of outcomes for liver transplant at Northwestern, we have excellent outcomes, again, 90+%. So, both living and deceased donation. So living donation is a great way for liver transplantation, okay? And we have very good outcomes here. So if anybody needs this, please send them our way. Okay, I'm going to briefly touch about pancreas transplant, okay? So we do pancreas transplant for type 1 diabetes, where patients have had some sort of immunologic reason for destruction of the cells that make insulin. Now we're doing pancreas transplant for type 2 diabetes, where people don't make enough insulin or they have insulin resistance. And it's really, pancreas transplant is meant to cure diabetes, okay? What it does, insulin is a good way to manage diabetes, but that requires you to check your sugars very regularly and often and be very on top of things, watch your diet in ways that are sometimes prohibitive or challenging. So a pancreas transplant is better than being on insulin therapy, okay? And despite being on insulin, you can still develop kidney disease, vision problems, heart and blood vessel disease, and peripheral neuropathy or nerve damage. So a pancreas transplant for many patients is a better way to treat diabetes, okay? There's a couple different ways, but the goal is to eventually get you to normal glucose levels so you don't have to check your sugars. It's basically working 24/7. It can reverse early kidney damage. It can prevent recurrent disease in transplanted kidneys. It stabilizes visions and it improves your quality of life. And again, we have really good outcomes. So in summary, key facts: transplantation is life-saving, okay? It does require lifelong medications to prevent rejection. There's both living and deceased donor options. Living donors return to a normal life, and we have all options available at Northwestern. So thank you guys for listening, and look forward to the question and answers.
Thank you, Dr. Katariya. That was excellent information. We're actually going to, when we come back to you in the Q&A session, I have a question for you regarding kidney pancreas transplants simultaneously.
Okay.
So we'll hold on to that thought. That was really good information. Our next panelist is Rachel Dahl. Rachel is currently a pre-kidney transplant nurse coordinator at Northwestern Memorial Hospital. Prior to working at Northwestern, Rachel was a nurse in the transplant intensive care unit in Mayo Clinic in Rochester, Minnesota. Rachel graduated with a Bachelor of Science in Nursing from St. Louis University, and we're really lucky to have Rachel here today. I think one of the things that most people in our community are probably not aware of is that transplant and transplantation is really a team effort. And Rachel will be discussing that here in a little bit. So thank you, Rachel, for joining us today. We really appreciate your time.
Happy to be here. Thanks so much. I am a transplant nurse coordinator. We'll talk about it, just one part of the transplant team. I specialize in the pre-transplant process for kidney and pancreas donors, but we'll kind of touch on all different, the different roles of the nurse coordinator. So yeah, just some objectives here to discuss our roles. We'll hit all those. So yeah, the transplant team is really it's a group effort, okay? So this is kind of the list of just the transplant team. As you can see, there's quite a few of us involved in this process. And so all of these people will you'll come into contact at one point or another in your transplant journey. And they all kind of have something to do with your transplant and use their expertise in the best way to manage you and your transplant before and after. And this is just the transplant team. So through your evaluation as a recipient, we may actually even send you to other consulting teams, cardiologists, things like that, that also play into this. So it's a big team and a big process. So that being said, this is kind of an overview of the transplant evaluation. So you always have to have a meeting with one of our physicians or surgeons in person so that they can do an in-person physical and evaluation. There may be some sort of relevant imaging that you have to do, a CT scan or an MRI. Like I said, you see a cardiologist for clearance, make sure your heart is healthy enough to go through a transplant surgery. And then all of our recipients need to have their up-to-date recommended cancer screenings. As Dr. Katariya had mentioned, one of the things that you'll be on lifelong is immunosuppression medications. And so those can, if there is a cancer present, they could make that cancer grow kind of unrestrained. So we want to make sure that there's no concerns for cancer. You'll see a social worker and make sure that there's a good financial plan in place for transplant. You need to have a good established support system. I'll talk about that a little bit more. And then possibly nutrition or physical therapy clearance, if those are things that are maybe going on with a specific patient. So for the living donor evaluation, this was touched on a little bit, but lots of blood work. So the first step is really a submission of a donor health questionnaire. So this is a document that gives us information about the donor's health history. So like Dr. Katariya and some others were saying, there are certain things that can mean that we can't proceed with a particular donor, different health conditions that they may have. So this gives us that information to start the process. They'll be evaluated by one of our social workers, or IDA is independent donor advocate. That's a role of someone who they don't deal with the recipients. They are just there as an advocate for the donors to make sure that they understand what the process of donation is, and that they have that person to talk to about their concerns. Once again, the age-appropriate cancer screenings are important. Need to make sure there's no evidence of any cancers in the donor as well. And then there may be some organ-specific evaluation items. So that's gonna consist of a visit with our team and then any relevant imaging, medical tests to ensure the health of that organ that's being donated. So the transplant nurse coordinator role, so again, we kind of break it down into pre-transplant, post-transplant, and then kind of the donor role, or the donor nurse coordinator role. So recipients, the pre-transplant recipient nurse coordinator, which is what I am. This is kind of the same for kidney, liver, or kidney and pancreas. So we're really that person who's going to be guiding you through the transplant evaluation process and then scheduling of potentially a living donor surgery. As you saw before, it's a very comprehensive evaluation, and there's a significant amount of testing that goes into it, and that can be overwhelming. So we are the gatherers of that information from the various consults and tests that you do to kind of create that complete overview of your case, and making sure that all of those various aspects of the evaluation are completed and completed safely, so that we know we can go into surgery safely. So we present your case to our team for either listing on the waiting list or approval to schedule surgery. All decisions are made by that larger transplant team. It's never just one person making a decision about your case, but we are the ones presenting that information to the team. And then we work with that multidisciplinary team to, again, just capture all those aspects of your case, make sure, like I said, that all of those things have been addressed. We are also the point person for any health status changes. So unfortunately, sometimes during evaluation, things change in a recipient's health status. Maybe they have a heart attack, maybe they have a heart attack, maybe they have some sort of infection that comes up. And those things can change the process and change what we may need to do in terms of transplant evaluation. So communication with the nurse is critical during that evaluation time, and for people who end up on the waiting list, critical, because that can be years of waiting. And so keeping us up to date on what's going on in your health during that time is very important. And then a large part of my job is educating about the transplant process. Again, this is a big undertaking, and it can take sometimes, months, years, depending on the route for transplant. And so we are here to walk you through that process and give you that education, because it's not something anyone's ever done unless they've had a transplant before, and it's a little bit different than any sort of other medical procedures and workups that you may have had. And then we'll talk to you about results as well that we find during evaluation and what implications these may have. And then something I'm not going to get into, we also coordinate the deceased kidney and liver offers. We won't get into that today. And so then for the living donors, this is for the kidney or liver. Our role is really, they're very similar. The point person for communication through the evaluation process. It's kind of a phased evaluation is how we talk about it, phase 1 through 4. And so we'll walk you through that step by step and what's expected at each part of that. And then it's also, again, education about the process of living donation, what the surgery, the expectations after surgery, and then the risks associated with donating. As said, we work with so that living donor advocate, we want to ensure that the donor is donating free of coercion or payment. They need to be doing this out of the goodness of their heart. And then the living donor coordinators continue to follow the donors after donation. The recipients go to a different team, but the donors will continue to be followed by that same nurse coordinator. And so for kidneys, there's follow-up post-op, 6, 12, and 24 months after donation. Liver, it's for the first 3 years. So we have those donors, those nurse coordinators continue to follow those donors. And then for the post-transplant role, they are the contact person for the patient to discuss concerns or changes in health status, especially immediately post-surgery. If there's any new symptoms that are coming up, they want to know about those so we can communicate that with the team. They also monitor your lab values and relay those critical changes to our doctors. So after transplant, you'll be on those immunosuppression medications like that's been talked about. And those have very specific levels that they need to be at so that we make sure that they are working. So they're watching those lab values, and then we'll communicate changes that are needed in terms of the medications or dosages with the patient. So that's a very important role. If those medication levels are off, if they're too low or too high, you can either have side effects if they're too high or potential rejection of the organ if they're too low. And then they also do, again, education is part of each role. a lot of education immediately post-operatively, especially about those medications, what restrictions you may have after surgery, and then maybe even necessary lifestyle changes. So pre-transplant kidney patients are usually on a fluid restriction. They cannot drink a lot of fluid because their kidneys aren't filtering it properly. But after transplant, that changes. We want you to drink a lot of fluid to keep that kidney well perfused with that fluid. So things may change in lifestyle afterwards as well, so they can educate that process. So some considerations for the recipient that we follow with as the team, where our goal is always to look at the risks versus the benefits of transplant. We want to make sure that we can improve your quality of life with a transplant. We're not going to make you sicker. It is a major surgery, so there are medical, psychosocial, and financial risks, and so our job is to educate you on those processes. As it's been talked about, we want to make sure you have adequate support after transplant. It really is a family, friends kind of process. We want other people to be involved. And then, of course, there's privacy and confidentiality on the recipient side, and that goes into living donation too. So we cannot share recipient health information with the donor, and we can do the same with the donor. So we can't share donor health information with that recipient. So considerations for a living donor, as it's been talked about, the safety of donation is the biggest consideration. So the donor health is the biggest question. Once there's a donor involved, we want to make sure that that donor, again, has no risk factors for developing kidney or liver disease. And if they do, we're not going to go ahead and proceed with that. We don't want to cause any long-term damage to a donor for them reaching out and doing this out of the goodness of their heart. That's not what we're looking to do. So again, it needs to be a free will donation. And then there also is that confidentiality of the donor evaluation as well. So this can be something that's frustrating for recipients because we can't share where the donor is in evaluation, who the donor is with the recipient. The donor can share that information with the recipient, but we cannot as the transplant team. So now the considerations for family and friends. So for family of recipients, the recipients are going to need 24/7 support for the first 2 to 6 weeks after transplant. And that could be longer depending on the specific needs of the recipient, how ill they were going into transplant. And transplant is a really big change. So the recipient should be feeling better. That's our goal. That brain fog that we were talking about and things, those symptoms usually go away after transplant, which is amazing, but the management can be challenging and overwhelming. It's a lot of new medications. And like I said before, those levels are very important. So the levels of those can be changing, and how you need to take them can be changing. And so those changes can be overwhelming for patients. So it's good to have someone else who is involved, who can listen to that information and reinforce it with the recipient. And then there's the consideration for caring for the recipient, as well as other people. So if a recipient has young kids, if their spouse also needs to take care of those children, maybe they are not the best support person for the recipient, we may need to bring in more family, more friends to help with that care model. And then we also have, Dr. Katariya touched on this, we have a living donor champion program. So if there's someone in the family of a recipient who wants to be the champion of helping that person find a donor, we have a program that kind of teaches you, that gives you tools and ways to approach that and get that recipient story out there to hopefully find a living donor, because that is the best route for transplant. And then so for family of donors, we really want your family to be supportive of donation. We want you to discuss that choice to donate together. That's really important. And then also, the donor needs 24/7 support for 1 to 2 weeks after donation. So, and that support person needs to be different than the recipient support person. Okay. So we don't want you to go through this alone. Obviously, your family is very important, but also we have resources as a transplant team who can give you that support through this process. So that's the first call always. We're here to help. We want to discuss your questions, concerns with you as the patient and your family. And then we also have other resources that we can connect you to. So the Transplant Village is a group of living donors and recipients from Northwestern that have kind of made it their mission to speak about and champion organ donation. So they have some resources. They're also involved in our Donor Champion program. And then there are also donor buddies and recipient buddies who have verbalized an interest in being buddies for us, so we can connect you with those people. And then UNOS and OPTN are the regulating bodies for transplant in the United States, and so they will also be an advocate for patient and family concerns. And then this is just a slide of where to contact us here at Northwestern if you want more information about either transplant, liver, kidney, pancreas, or kidney or living kidney or liver donation. And that's all I've got.
Right. Thank you so much, Rachel. We really appreciate you sharing that information. Again, if you want to put that last slide back up just for a quick second,
Sure.
for anyone who does want to, again, make note of any of the contact information, you can take a quick screenshot, take a picture with your phone to get that information fairly quickly. Again, this is Northwestern's information that Rachel is sharing. The kidney pancreas transplant, liver transplant recipient, kidney living donor. Again, take a quick screenshot if you can. We've been able to hear so far from a lot of the medical experts and the clinical experts on kidney donation, liver donation. We do have a couple questions at the end as well. For those of you who are still here and are able to stay on, I ask that you do stay on for our final speaker because her story is quite important, is a very unique perspective as well. And if we got Sister Khaula here. Rachel, again, I do want to thank you for your time. And if you just want to stay on at the end as well, we are going a little bit over, but again, we're okay on our end if the attendees are able to stay on for a little bit longer. I want to introduce Sister Khaula. She is part of the North Shore community as well. And she's currently a mother of three, is a lab technician at North Shore in Evanston, Illinois. And if you saw our flyer, you saw that she is a transplant recipient. And so again, Sister Khaula has a very unique perspective of her journey and her story and how she came to be a recipient. So Sister Khaula, if you can take over from here and please do share your story with the rest of us. We appreciate you being here as well. And for those of you who are able to stay on after she's done, we will go over a couple questions as well. Feel free to include that in the Q&A section. If you're not able to find that, you can include that in the chat and we'll still find it, I believe. Thank you.
Assalamu alaikum, everyone. Bismillahirrahmanirrahim. My name is Khaula Chaudhry, and I am a kidney transplant recipient. Like Brother Omar said, I'm married with 3 children. And I had gone through kidney transplant back in 2014, and I would like to share my story to educate our community. I actually found out about my kidney disease back in, I think, around 1995 when I was going through ultrasound school when we used to practice. So at that point, when I saw that, and my instructor was kind of like looking at that, and she said, seemed like something concerning probably. So she suggested to see a nephrologist. I visited the nephrologist probably a few months after that, and they had stated that I have polycystic kidney disease. And right now, since I did not have any symptoms, I did not need to do anything. But down the line, you probably will develop symptoms, and end result will be kidney transplant. So that was a lot to take at that point. But after I saw a nephrologist, And they shared the option, just make sure I'm being monitored throughout, and keep an eye if there is anything else that unusual that shows up in your lab work or anything else. So I kind of kept an eye on it for a long time. After a few years, I started developing high blood pressure, which is a side effect to the polycystic kidneys. And I had to start taking medication for that. Moving forward to 2012, as I was being followed up by a nephrologist, my kidney function had deteriorated quite much. And she had recommended that in a few months, you might have to start doing dialysis. So then I had to make a choice between hemodialysis or peritoneal dialysis, because like a couple of Dr. Ahmed has said before that for hemodialysis, you need fistula or IV. So I decided to go with the hemodialysis and also doing it at home instead of going to a clinic to have it done. It is a long process. It takes a lot of time. So there was a lot of education done before I started. I had the fistula placed in July of 2012, and 2-3 months after, I had started doing hemodialysis at home. During that period of time, you have your energy level is low. As I was working also, I was working not full time, but like 32 hours. So I had to make changes in my schedule and start doing dialysis at home. I decided to do it every other day instead of doing it 3 times a week, because that fit for my schedule and my family. And during that period of time, I would come home from work, and after taking lunch or whatever need to happen, I would start my dialysis, which will take 2 to 3 hours from the setup to the end. Actually, sometime it will take 3.5 to 4 hours. During this period of time, I was being continuously monitored by the nephrologist, and they had recommended also to sign up for transplant. The options were live donation, or the other option would be deceased. My preference would be live donation, because you can get it quicker and you don't have to wait so long. I had gone through actually referral to Northwestern and started the transplant procedure there. And I was told during the process that it could take 5 to 7 years. That was kind of disheartening. So I also found out that I could register at other states also. So I decided to go to Mayo and also UW Wisconsin to register there. The reason being was the time would have been shorter if I had option of getting a deceased donation. Couple of my family member did think about it, but it kind of did not work out for getting a live donation. So in during this period of time, I was going through dialysis. I cannot thank enough to my family. My children were young at that time, just staying awake later and later, and they would have school the next day. I would start up the dialysis process, and then I would need help towards the end to take it off, because it takes time and you would really need help at that time. So my husband and my children, who were very young at that time, like 12 and 13, and the youngest one was 7. Alhamdulillah, alhamdulillah, they were my angels, or they still are actually. And without their help, I would not have been able to do it at home. During this process, I also had, other complication. In 2013, I had to have a pancreatic surgery because I had developed stones in my pancreatic duct, and I was just having too many issues with that. So I had to have a major surgery before I was called for transplant in 2013. During that period of time, I had no energy at all and just too much excruciating pain. So I had to have the dialysis done at a clinic, which was great, but that takes another toll in your life. Then you have to drive to the place, spend 3 to 4 hours there, and just the tiredness altogether would be overwhelming. Alhamdulillah, in 2014, in August 2014, I got a call from UW for a transplant, midnight on 28th of August. Alhamdulillah, so we had to go there to get the transplant. We had to be there within like 4 to 6 hours of the call. So alhamdulillah, we had the transplant the next day in the evening, and right away, like brother stated before, that the fog was lifted, you had a lot of energy, and you were able to like you were recharged with the new kidney. So alhamdulillah, I was transplanted 28th, and then I had to start taking the transplant immune suppressant medication. So those have effects of their own. The immune suppressant, one of the causes, because it's a steroids, you even though you're not a diabetic, you can become a diabetic. I do have diabetes in my family, so I became a diabetic afterwards. But I had prior symptoms before, but I didn't have to take medication. So right after the transplant, I have been on insulin, trying to manage diabetes, trying to manage the kidney functions, but alhamdulillah, it has been well. And without my family and my friends' support, I would not have been here. And like Allah has said that your body is amana, so we have to take care of it. We have to educate ourselves and get what's available. And if you don't have information, please reach out and get the information so you can be taken care of. Thank you for everyone.
Thank you, Sister Khaula. Sister Khaula, can you just briefly go over also, just for a few seconds, how your quality of life and daily living has improved since getting your transplant? And again, if you can touch on what year again that was and how you are today.
So alhamdulillah, I got transplant on August 28th, 2014. So it's been 6 years. My quality of life has been much better. I don't have to be attached to a kidney dialysis machine for 4 hours, 3 to 4 hours every other day. And I'm working full time. And I mean, after work, when you get home, you are tired because you're consistently moving at work, and you have to take breaks. And but alhamdulillah, it's much better than while I was on dialysis.
That's great. Thank you so much again for your, your personal story and your perspective. And inshallah, if anyone has questions for you, they can ask you now. But again, if anyone maybe doesn't have questions at the moment and thinks of it later, or if they don't feel comfortable asking here, you can always, again, reach out to us at health@mccchicago.org. Again, that is health@mccchicago.org. And inshallah, we will try to get your questions answered. I have Ishaq back here now as well. We can go over a couple questions real quick, and inshallah we'll close out pretty soon after.
Thank you, everyone. We'll try to wrap up here with a few questions and then make a quick dua from Imam Ibrahim and then wrap up for the day. If you have a question that you'd like for any of our panelists, please try to use the Q&A function at the bottom. If you click on that and enter in your question, we'll certainly try to filter it and address it to our panel. I wanted to start off with a question for Doctors Ahmed and Katariya. One of the things that's really common within our community is diabetes, high blood pressure, and kidney function or loss of kidney function as a result of those comorbidities. I think most of us just resign ourselves to having insulin treatment for the rest of our lives. And one of the things that you brought up that was really interesting is the fact that we can actually cure people of their diabetes. So can you talk a little bit about how the two go hand in hand, and possibly how we can hopefully move people so that, one, they regain a new kidney, but also possibly are free of insulin and other medicines in the future?
Yeah, so I can talk a little bit about that. So, as you said, a lot of kidney disease goes hand in hand with diabetes. And so we do have an option. We have different pathways to treat the diabetes for those who are on insulin. And there's some deceased donor routes, and there's also living donation routes in terms of the kidney portion. So when patients present to us with both kidney disease and diabetes, we discuss this with all of them. And we can do what's called a simultaneous kidney pancreas transplant, which is from a deceased donor where we get both a kidney and their pancreas. This is obviously a bigger operation than getting a kidney transplant alone. But the goal is to cure both, get you off dialysis or prevent you from ending up on dialysis, and also treat your diabetes. And this is an excellent way. Some patients do have a person who could be a potential living kidney donor, and we could do that transplant first and then do what's called a pancreas after kidney transplant on the deceased donor waiting list. And this is a way to sequentially kind of treat your kidney failure first and then your diabetes second. The important factors to know, though, are for people with diabetes that's diet controlled or with, oral medications, this is not for them. It's for people on insulin. And typically we have some weight restrictions because of insulin resistance. So patients, we try to get patients below a body mass index of 30, but we talk with patients between 30 and 35. And if you look at the literature, for patients who have long-standing diabetes and insulin are on insulin, some can take very good care of their diabetes, but still it's not as good as a pancreas transplant. And it's not for everyone. We're really looking for the people who have the hardest time managing their diabetes, because it does require immunosuppression. It doesn't last forever. And so, people who are having very low sugars, very high sugars, not great control, and a lot of second and end organ damage are the patients we sort of pick first.
Dr. Ahmed, did you any?
Yeah, just echoing what Nitin said, the folks that have chronic kidney disease secondary to diabetes, depending on sort of how long they've had diabetes, whether they have type 1 versus type 2. Type 1 patients are generally the ones that I would have referred for transplant. The type 2 diabetic patients, even those who are on insulin and have had some degree of kidney involvement or eye disease involvement, if their diabetes has not been under good control, one of the first things that I focus with them on is taking advantage of the strategies that we have to control diabetes, having them understand the importance of weight loss, diet, lifestyle modifications. I've seen patients who are type 2 diabetics on insulin therapy. They undergo a significant diet lifestyle modification without doing any bariatric surgery, but just really taking ownership of their eating habits and so on. They lose weight and they come off their insulin. And so type 2 diabetes, again, is nature and nurture, like we talked about previously. And if we can, again, take advantage of some of the resources that we have in weight loss and controlling those risk factors for progressive diabetes, particularly for the type 2 diabetics, when a lot of it is nurture, then I think I have seen patients come off of insulin. I've seen patients come off their diabetes medications, like the oral medications. Type 1 diabetes, of course, is a very different beast altogether. And there is a genetic defect, and those patients start off on insulin at the get-go. And those are the patients that I would refer for transplant if they have kidney disease involving secondary to diabetes. You can hopefully take care of both those problems simultaneously if they're a candidate for pancreas kidney transplant. So long and the short of it, I think, is the folks who have type 2 diabetes that's not under good control with the targets that are not being met, doing what we need to do with regards to diet and lifestyle, you can really impact sort of the progression of the complications they get from diabetes if we optimize those risk factors.
Dr. Katariya, we have a follow-up question. How long is the waiting list for pancreas transplant, and how common is it for diabetes?
So the wait list depends on your blood type. O and A are the most common blood types. So those have typically a little bit longer wait time, can be 1 to 2 years. It depends if you're have kidney failure and are on dialysis, that wait time starts back to when you started dialysis. If not, it starts from when you're listed for transplant. For blood types B and AB, it's a little bit less time, but we're the most aggressive pancreas transplant program in Chicago. And so we get organs from outside our state a lot and things. So it can be shorter. And then your second question was what? I'm sorry. How often do we do it? So, volumes are varying. So like we do about 100 liver transplants a year, a couple hundred kidney transplants, and about kidney pancreas transplants, you're doing about 20 to 25 a year. So it's not as nearly as common as the other two. But, it's very effective for those patients that fit the criteria.
Okay. We've got a couple more. Dr. Nitin, maybe you can talk about this one because you brought up the liver donor aspect. And one question that someone had asked was, how does one liver donor survive?
So live liver donors, the unique thing about liver transplant or healthy livers is they regenerate or grow back. So when we do take part of a liver of a liver donor, it grows in both the donor and recipient. That partial graft will grow back in the recipient and also the liver donor. We're not taking their entire liver. They need part of that liver to grow back. And so that's what happens. And they have normal life expectancy. They do very well. So, it's really a good process. But our job up front is to highlight and make sure there's no risk factors for them to have liver disease when we're working them up to be a donor.
And this one, Dr. Ahmed, if I can ask you, is about hydronephrosis. So will subjects with conditions identified as hydronephrosis eventually require a transplant, or will they need dialysis? Is it also reversible?
Sure. So just so everyone else knows what hydronephrosis is, this is a process where both kidneys are doing what they're supposed to do in allowing for filtration to happen and the urine to be made. That urine goes through the drainage system and eventually ends up being stored in the bladder to be eventually excreted out into the outside world when the patient's ready to urinate. So hydronephrosis can happen on one side if the drainage to one kidney is blocked, or both sides if the drainage system to either both kidneys or the bladder or downstream is blocked. When hydronephrosis happens, typically if it happens over a very long period of time, and it's a slow process, the bladder will start, if it happens at the level of the bladder will start to get bigger and bigger and bigger. And the urine is being made, but it's backing up into the pipes that drain the kidney, eventually backs up into the kidney, and can incur kidney damage if that blockage is not relieved. And so to give you an example, I had one of the most significant hydronephrosis patients that I saw back when I was first starting my practice in LaGrange. This patient presented with really what looked like a pregnant belly. And he had a bladder that was so distended and it was so enlarged that his belly was protruding as if he was pregnant. And he got drained, and he had 5 liters of urine that was drained. And over the course of the next several months, he was initially on dialysis. Over the course of the next several months, his kidney function did recover. Now, whether the kidney recovers or not depends on a number of different factors. If they have underlying kidney disease that's advanced, and then you sprinkle on severe hydronephrosis that's prolonged, the recovery may not be a full recovery. They may need to be on dialysis for a longer period of time. But generally speaking, a blockage of the drainage system causes a condition in the kidney that is reversible about 70 to 80% of the time. That condition is called acute tubular necrosis. Typically, that's the pattern of injury that we see in kidneys that are blocked up. So if it's a hydronephrosis that occurs over a long period of time and eventually it is drained, then the recovery is very quick. On the other hand, patients who have a hydronephrosis that occurs over a short period of time, let's say because they have a blocked, a kidney stone that's blocking one of the drainage systems, one of the drainage pipes leading from the kidney to the bladder, they usually present with significant pain because it happens over a short period of time. And when that ureter starts to expand, that leads to a lot of pain and blood in the urine. When that kidney gets drained, their kidney function recovery is going to be hours to days. But then there are those patients who are presenting with a blockage that occurs over a much longer period of time. Let's say they have a prostate that's enlarged, and over the course of weeks to months, they are going to the bathroom, they're trying to pee, urine is not coming out, they're making more urine, and over that period of time, the bladder starts to accommodate a larger volume of urine after urination, after they pee. That bladder will eventually get distended and more distended, and they can present with creatinines I've seen as high as 12, 13, and their BUNs, which is another lab value that we look at, is in the hundreds. And we drain that bladder, and because of the fact that it's typically a reversible condition, we watch and wait, and it usually recovers with, maybe not a complete recovery, but enough that they don't need to worry about dialysis. The creatinine may come down from 10, 12, down to a creatinine of 1, 1.1, 1.2. There may be some scarring that's left behind, but largely this kind of kidney failure is one that leads to recovery once the drainage system is unblocked.
Okay, thank you for that informative answer. I actually want to bring Sister Khaula on as well, and maybe Dr. Katariya and Dr. Ahmed, you can chime in with this as well. But Sister Khaula, one of the other questions that we had was, after you had gotten your transplant, how would you say, as far as how many medications would you say you were on at that time? And has that come down since?
So there are 3 medications that I have to take consistently because those are immune suppressant. Initially, I was on more with the pain medication and just to adjust everything. But right now, I'm taking 3 specifically for the kidneys. So yeah, it has came down quite a bit. But they have to, like Rachel was saying, the levels has to be adjusted. So I usually get a blood test every month to monitor those. So make sure the level stays between 5 and 7. And it is critical to make sure you take the medication on time. You have to take it twice a day, every 12 hours. Because if you're not consistent with your medication, your kidney function can start to reject also.
Dr. Ahmed or Dr. Katariya, do any of you want to chime in on that as well? Dr. Ahmed?
Yeah, so I think Dr. Nitin is probably going to be a lot more qualified, or he deals with the post-transplant medications a lot more than I do. But in general, the number of medications that the person takes is going to be dependent on their risk for rejection. The greater the risk of rejection, the more immune suppression they're going to need to prevent that rejection from happening. And they absolutely have to be psychologically evaluated to ensure that they're going to be compliant with those medications, because a lot of effort is being put forth to give them the kidney. And that's all part of the pre-transplant evaluation. I tell my patients who are on dialysis, who are missing dialysis, who are not taking their medications that they need to maintain their health, for example, the medication that they need to maintain good normal electrolytes, if they have proven to be a non-adherent patient and they're not taking their medications as they're supposed to, and they keep presenting to the dialysis unit with labs that look horrible, they keep missing their dialysis, the transplant centers are going to look at that and see that the patient is not a responsible patient. And so to invest resources, to give them a kidney when they haven't proved adherence to the basic regimen that's been prescribed by their nephrologist, really it can foretell how they're going to do with taking the transplant medications post-transplant. So typically that kind of information is important for them to help maybe start taking their medication like they're supposed to and start being good citizens on dialysis. And so with regards to the transplant medications, there are greater and more research and trials that are being done that I'm superficially familiar with, where they're really trying to use the minimum amount of immune suppression that is needed so that you don't put the patients at risk for cancer and infection, but at the same time you preserve their kidney function. And so Nitin can probably speak to that as well and expand on that.
Yeah, so those are all great comments. So in general, for most patients, you're on 2 to 3 medications for post-transplant care. And again, it really does depend on your risk for rejection. We wean the doses and the levels over time as your body accommodates. And we sometimes switch them around a little bit depending on kind of other risk factors. Some of these medications can affect your kidney function in the long term, so we try to wean those. We switch. And so people are doing research, as he mentioned, on different types of medications that can be easier. We have some new medications that instead of a pill, you get an IV shot once a month, which is a new way that we found for patients who have challenges taking their meds twice a day. And then there's a lot of studies going on trying to eliminate immunosuppression altogether. One of my partners, Dr. Leventhal, has been doing a lot of research on this, where you can get a stem cell transplant at the same time as a kidney transplant and get off all this immunosuppression. It kind of teaches your immune system to accept the organ as part of your body. And we've had some good success with this. So there's a lot of smart people working on ways, because, it's a challenge. I mean, it's not easy every day to take multiple pills twice a day. And so we need that compliance, because this is a gift, whether it's a living donation or a deceased donation. You saw how many people are waiting on the list. There's, hundreds of thousands of people who need transplants. And so we need patients to demonstrate that they are compliant and can stick to this. And that's part of what the evaluation is, just to ensure that you're on the right path so we have the best outcome for you and your health. So.
Excellent. Thank you so much. I'm also going to bring on Imam Ibrahim, and I'll ask Imam Ibrahim this from a religious perspective, of course, but also any of the physicians, if they want to chime in also, because this is something that was brought up a few times. And this is something that I think comes up in a lot of other areas outside of the US, but could be a potential issue here as well. Something that someone had asked was, what about donating, organs for money? This happens in different parts of the world. And so again, Imam Ibrahim, if you can speak from the religious perspective, of course, and then if any of the physicians want to chime in or clinicians want to chime in on what are some of the ways that we mitigate this. I know there was talks about, how do we want to ensure that there's no coercion involved. Is there any deeper research that's done to ensure that that's not an issue,
Actually, before my surgery, the coordinator had asked, is your dad paying you? I jokingly said he has to pay for the wedding, but so contracts in Islamic law have certain conditions, right? And from the conditions that a valid transaction has to happen is that there has to be ownership over something. It can be disputed that you do not own your organs. It's not property. It's something that's a part of you, but you don't necessarily own it like you own a house or you own a car, and so you can't sell it. Another objection, the jurists would say that you're not allowed to sell something at the expense of your health, because there is a risk factor when you're donating. Negligible as it may be, there is that factor, and so you're not allowed to sell something that puts you into that risk. And then the third thing is that it's kind of like if you were to compare it to anything, it would be like what we call a qard, which is a loan. Islamically, when you loan something, it's actually it's not something you're trying to profit out of. It's actually something that you're trying to help someone. That's the original Islamic outlook on what a loan is supposed to be. Capitalism kind of looks at it differently, but the Islamic sense is that when you loan someone money, you're trying to help them out. You don't care about inflation. You don't care about making money out of it. You're trying to help them out. and if they can pay it back, they can pay it back. And so when you're giving someone something, it's out of you're trying to help somebody, right? You're not trying to profit out of it, and so you're not. There's profiting off your body is an illegitimate transaction Islamically from all the angles that you can possibly look at it from. So yeah, it's not a legitimate transaction. If somebody took money for it, they have to return that money, and just accept the consequences.
Yeah, and even selling to survive or livelihood, I'm assuming that is also something that would be considered prohibited, right?
What do you mean?
One of the questions was if you're selling an organ to survive or for your livelihood. That's just kind of an extension of the question that was asked. Again, it's the same concept basically, right? We're not supposed to be selling our organs.
Yeah, it doesn't seem like a valid. There are other things you can do to survive, and
Yeah.
Thank you. And so Rachel, also, if you have any insight, maybe as the transplant coordinator, if not, Dr. Katariya or Dr. Ahmed can chime in as to how we kind of mitigate this, or if there's any further research that's done.
Yeah, so, kind of talking about those confidentiality things between donors and recipients, throughout the process, there are moments when we talk to the donors by themselves. We want to make sure that we've met with them alone without their recipients to make sure that they feel that they can share information with us about what may be going on with their motives and why they want to donate. And so one of the ways we do that is talking to them alone and talking about this exact question, payment and then coercion, and that they're feeling they don't have that pressure of that person there. And the other thing too to tell potential donors is if there is ever a reason that they did not want to donate, we will not share that with the recipient. So if they tell us that they don't want to donate for whatever reason, that's fine. We will always support that choice. That is their choice. And then we, again, don't share that with the recipient.
Yeah, those are all great comments. And then just briefly, we discourage what we call transplant tourism because there's a lot of high-risk behaviors that get done around the world where people are sort of purchasing organs. And really what's happening is people who are at financial disadvantage are selling their organs for very little to support their families and these other things, and not getting the appropriate follow-up and care like we do here. Our first job is to protect the donor because this is a surgery they don't need. There's no medical benefit to them. So if we know that they have a potential risk for kidney failure in the future because they have a little bit of high blood pressure, we're not going to allow them to be a donor. That's not happening when people are buying kidneys in the rest of the world. And so we really strongly discourage this. I know it's legal in 1 to 2 countries, and it just encourages and is a slippery slope in terms of taking added risk for the donors that shouldn't be done. And so we are very against this as a transplant community in much of the world.
I appreciate that insight. And so, we are getting close to 1 o'clock at the moment, so we should be wrapping it up. I know we have a couple other questions in the Q&A. What I would ask again is for anyone who does really have a dire question, wants something answered, even the ones that are in the Q&A right now, if you can forward those questions to health@mccchicago.org. We do want to close this out right now. Again, it's health@mccchicago.org. I am going to bring back Imam Ibrahim real quick. I do want to also, give a quick thank you to everyone for taking part in this, for taking out the time, on a Saturday morning to educate our communities. As I had mentioned, we've had a number of individuals that have attended this webinar live, but this will also be put up on, YouTube, Instagram, and portions and things along those lines. And I'm just going to share the last slide that I have as we close out. And this again is just some follow-up information. If anyone is looking for continued resources, health educational information, you can find us again on Instagram. It's at MCC Health Committee. Facebook, you'll find some information under Muslim Community Center. And YouTube, if you just type in MCC Health and Awareness, you will find a few videos that we posted up there. Again, it is breast cancer screening and awareness, mental health topic, as well as colon cancer screening. And now this seminar will, inshallah, be up soon as well. Again, we do ask that you reach out to us at health@mccchicago.org and share other topics that you have interest in that we can, again, address in the future. Bring on experts such as the ones that were here today to really share that information. If you have speakers that you also feel like you can recommend, please share that information there as well. And again, our aim is to really engage the community, you know, bring about this health education, and when people know better, they do better. You know, so there's a lot of topics that we have yet to discuss moving forward. But we really appreciate everyone being here. I do want to also say a very special thank you to Sister Balbina for providing the American Sign Language interpretation for us this entire time, and really being able to create another means of communication for a number of individuals who may not be able to have that access otherwise. So as we're closing this out, if I can ask Imam Ibrahim to take us out with a prayer or a dua. And then inshallah we'll sign out. And again, anyone else who does have further questions, please reach out to us at health@mccchicago.org. Again, I do want to say a very special thank you to Dr. Mohammed Ahmed, Dr. Nitin Katariya, Sister Khaula Chaudhry, Rachel Dahl, and Imam Ibrahim, as well as Sister Balbina.
Jazakallah khair. We ask Allah subhanahu wa ta'ala to bless us with good health and to protect our livelihoods and to protect our families. We ask Allah subhanahu wa ta'ala to give us serenity and to strengthen us and increase our perseverance in face of difficulties and obstacles that we may go through in our lives. We ask Allah subhanahu wa ta'ala to accept all our good deeds. We ask Allah subhanahu wa ta'ala to protect us from the evil of ourselves and to guide us to what's best. سبحانك اللهم وبحمدك نشهد أن لا إله إلا أنت نستغفرك ونتوب إليك والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. السلام عليكم ورحمة الله.
Ameen. Thank you. Thank you all again. Really appreciate your time. We will be ending this chat now, and inshallah, if anyone does again want to follow up, you can do that at health@mccchicago.org. Thank you all for your time. Thank you for your knowledge and for sharing this information today. I believe a lot of people, inshallah, will benefit from this. Thank you so much. Take care.
Thank you for doing this.
Bye.
Assalamu alaikum.